Hi everyone, I'm going to record some of these slides for you to make it easier. Renal and kidney, we'll start off with a few things on the renal and kidney disorders. Renal failure, these are some questions that you can ask about evaluating your patient and some of the things that you can prepare for. For example, you want the patient to have a decrease in blood pressure, you want them to have minimal side effects and adverse effects. When it comes to the drug therapy. Some of the medications that we use for renal failure will relate to the complications, and this slide shows you all of the complications we see, and then the treatment on the far right, and then in the middle, the reasons why the kidneys are doing what they do when they're failing. So you can read over this, but we're going to be giving possibly Epigen or Procrit for help with red blood cell production, dietary restricting some potassium if they have a lot, or giving them Kayexalate to get rid of the potassium. The extra phosphate that kidneys are unable to excrete, we want to get rid of that, so phosphate binders. And then kidneys are unable to excrete the excess sodium in water, so causing water retention and edema. So we're going to give them some of the diuretics that we have already discussed in class. And then correcting their hyperphosphatemia will also correct their hypocalcemia, because those two, remember, have an inverse relationship. And then possibly needing to correct metabolic acidosis. So those are some things to consider. And then also consider what are some foods that are high in potassium so that you can talk to your patients about restricting those in their diet. And again, here are some more questions for you to think about. Assessments to make when it comes to patients you're giving diuretics to, and what is some teaching components that you can add in your care of a patient taking a diuretic. And that should be every time you have a patient taking a diuretic. So think about the giving Lasix, 20 milligrams even should be, you need to think about the teaching to incorporate. So here's some pictures depicting the types of diuretics you'll see. These are just a review because this is not the focus this week, but of course, renal failure, we do use diuretics, so we need to have that in our toolbox. The osmotic ones acting on the proximal tubule and the loop of Henle, creating osmotic force, pulling water into the nephron and increasing excretion. And it excretes all the electrolytes as well because it's working way up here. And then you have loop diuretics working on the loop of Henle, blocking reabsorption of sodium chloride and water. Potassium will also be excreted, and then we have the thiazide diuretics working up here on the distal tubule. And then we have the potassium sparing, which of course will hold on to potassium. So if a patient is hyperkalemic, we do have to be careful of this drug. So these are why we have choices. So important for us to consider all of those side effects. This one I just threw in here to mention. It's a miscellaneous diuretic used for glaucoma. It doesn't really have the same effect as the other diuretics, acetazolamide or Diamox, but it is one that you should be aware of, and it's in your workbook, so I threw it in here. If a patient has an allergy to sulfamides, they will not be able to take this drug, so that's another thing to consider. Drugs for UTIs, so we are going to talk a little bit about antibiotics, but there are some specific drugs just for antibiotics, just for UTI. They work on the urinary tract effectively. And these are some names of drugs that are specific to that, which we'll talk about. This first one, Monurol, usually used for uncomplicated UTIs. It has a bacterial effect against most gram-negative, gram-positive. Side effects, of course, are diarrhea, headache, and there's more listed here. Oops. Quinolones, one example is norfloxacin. There's quite a few of these types of quinolones. Cipro is one you probably heard before. And these have more of a broad spectrum antibacterial effect. Can be used for other things. Great against gram-positive, gram-negative. Of course, remember that whenever we're treating UTIs, we need to get a urine and send it for culture. So get a clean catch, dip it, and look for bacteria, nitrites, and lymphocytes, of course, and red blood cells, and then we send it off for a culture before we start treating the patient so that we can get the right antibiotic on board. And there's some side effects to this one. Photosensitivity, photophobia, those are important things to note if your patient gets those, to report to the physician. This one, mandelamine, this one works well for recurrent UTIs and pre-existing infections the patient has. So do not crush these. So there may be patients who we don't want to give these to. And then side effects to report, of course, are some of these really bigger ones like the hives, the pruritus, the rash, that kind of thing. And it does have some drug interactions. So this one you've probably used before, macrodantin or nitrofurantoin. This is a bacterial static and a bacterial bactericidal. It's a common one. It's been out for a really long time, like in the late, I guess it was the early 50s, 1950s. It's useful for any gram-positive, gram-negative, E. coli related or chronic and acute UTIs. You know, how the doctor chooses some of these, it really depends on the patient's history. So if this one's useful for a lot of patients, then we'll go ahead and give it. So we look at their history, we look at how often they've had UTIs, and then it's certainly a good go-to drug. It's not super expensive. Bladder active agents. So these are urinary stimulants to make the bladder work better. And this first one, uricoline or bethanechol, basically works as a direct-acting parasympathetic or sympathomimic. I can say that 3 times. Increasing bladder tone, increasing the tone of the muscle in the urinary tract. So let's look at this one again. Here it is, causing contractions of the detrusor muscle, urination, stimulates gastric motility. So it does have some other effects as well. And side effects, flushing of the skin, headaches, and then of course there's some that should be reported. This one is used mostly for the post-op patients, sending them down to the floor or going home. Sometimes patients will have this one to prevent urinary retention post-operatively. It does have other side effects, and it is used for other disorders. So it's only used temporarily after surgery for this situation. Oxybutynin, antispasmodic agent, and it works directly on the smooth muscle of the bladder. It delays initial urge to void. And then there are some conditions listed here that it should not be used if you have these side effects, of course. But there are a lot of people who take ditropan or oxybutynin. Um, and then pyridium, you've heard of pyridium because pyridium is that anesthetic that we use only on the urinary tract. And it doesn't have a long half-life or effect, so you can use it for 30 minutes after administration, and it's in other words, it'll work for about 30 minutes to an hour, helping to reduce the pain, the burning, the the dysuria of UTI, reducing the bladder spasms as well. The side effects is mainly the red-orange colored urine, but some patients get it into, gets into their skin, and they should report that. This one, Detrol, is another common one used. It's a muscarinic receptor antagonist. It inhibits action of acetylcholine on the bladder muscle. So it's used for overactive bladder. A lot of women will take this if, they have to pee a lot and then they're out, and they can take this and it'll slow the urge much more when they're out and about. The side effect can be urinary retention and hesitancy. So that's something we would monitor for in a setting of a hospital, or if they report that when they come into the clinic. And then, of course, there's some reasons why they shouldn't use it here, listed here. Here are a couple of questions to think about when you're treating your patients for urinary tract system problems. What are some education guidelines for the drugs? What are some nursing diagnoses that you would find useful for these clients receiving diuretic therapy? And then we're going to move to the immune system drugs. Antibiotics, antimicrobials, anti-infectives, antivirals. We've talked about some of these already, but here is your little blurb on microbes. There are a lot of different microorganisms, and bacteria is just one, but we have viruses, fungi, and protozoans. We do find that there's a lot of organisms that are effective in our bodies that we should try not to eliminate all of the microbials from our bodies, because they are normally useful, and they are a way to protect us. So we don't want to get rid of all of them. We only want to get rid of them when they multiply and cause harm and make us sick. That's when we want to get rid of them. So antimicrobial therapy is an amazing thing when you need it, for sure. And this is when we would treat a patient for an infective organism that is causing them to be sick. Again, we like to determine what it is the organism is. So when we do a culture, really important to find the correct antibiotic or antimicrobial. Sometimes we use antimicrobials before, during, or after procedure to prevent infection. We often do that pre-op antibiotics given, and then during the procedure, and then after. So it really depends on the reasons. There's some different reasons. And then here's a bacteria. Think about back in your microbiology days and gram staining. Gram-positive stains are purple, gram-negative stains turn red, and they're harder to kill. And then if you want to look back at your bacteria and how we actually invade, we usually work on the cell layers, so the lipid layer of the bacteria, and these antibiotics work to destroy the cell of the bacteria, and then it dies, and then eventually more and more die, and then they're not able to continue growing. There is such a big controversy now over use of antibiotics. We have resistant bacteria that are not able to be killed that easily. So That's why they say only use an antibiotic if you absolutely need to, especially the broad spectrum types. So we should always use the least invasive or the least amount of antibiotic to kill the organism. So that's something that the providers are working diligently on doing. But one of the teaching things, take homes for that is you need to teach every patient on an antibiotic, especially if they're going home with it, to take the full course that they've been given by the provider. So once they stop midway, it gives the bacteria an opportunity to become resistant and thrive in the conditions because you've only taken part of the antibiotic. And then that's one of the ways that we are seeing some of the bacteria problems. So if they're going to take the course, take the full course and make sure you teach them that. Superinfections are secondary infections that patients get after they start taking an antibiotic. And an example would be a yeast infection, either an oral thrush or a candida or some kind of skin. And some people get vaginal infections every time they take an antibiotic, yeast infections. And those, of course, we would treat, but it's another infection that we now have to treat. And C. difficile is one that we call a secondary infection because most of the time that people get it, it's because they've taken this long course of antibiotics in the hospital, and now they have diarrhea that's turned into a colitis, and C. difficile is the organism that has taken over. There are lots of adverse and allergic reactions to antibiotics, and that's another big issue when we're dealing with patients is that some of them get very sick on them. So we need to consider taking them off, changing the antibiotic. So it's not like it's just a piece of cake, a walk in the park. You give a patient an antibiotic, they're good to go. There are so many problems with antibiotics, especially in elderly folks, that it shouldn't be a quick go-to, and providers should always consider other courses of treatment before they go to antibiotics. So look at some of these adverse reactions: GI upset, nausea, vomiting, diarrhea, headache, allergy reactions, hives, itching, stridor, wheezing. I mean, these can be severe. So if they have a documented history of having an allergy, then we would avoid that antibiotic, of course. And that sometimes limits what we can give them. So now we have a shorter list of things. So here are some ways that the antibiotics work on the cell. Again, I said that some will work on the wall. So interfere with wall synthesis, and that's your beta-lactams. Interfere with protein synthesis, that's your aminoglycosides, your tetracyclines. RNA, interfering with RNA and DNA replication, and there's quite a few drugs that do that, but a couple quinolones, Flagyl, rifampin, those are a few that do that. And then interfere with metabolic activity of the cell. So like protein synthesis, and that would be your macrolides, your clindamycin. So they all work on different parts of the actual organism cell, and so some of them work better for certain types of microorganisms. Again, if they're gram-positive, they're gram-negative. I'm not going to get into all of that because you guys can certainly go review that in your micro books. Sulfonamides, Bactrim and Septra, these are other names. Trimethoprim. These are excellent drugs for UTI. They are an older class of drug, but they work really well if a patient does not have a sulfur allergy. So if they have a sulfur allergy, they can't take these. They do inhibit bacteria growth. They're considered broad spectrum. And you're not supposed to mix them with sulfonylureas, warfarin, or phenytoin because of toxicity. of those drugs. You have to be careful. A lot of antibiotics interfere with the action of other drugs and either potentiate, in other words, make those drugs work much better, which is not always good, or interfere with the way the drug works, like in, for example, oral contraceptives. So, and whenever a woman is taking an oral contraceptive and then gets put on an antibiotic, she should be considering using an alternative method of birth control while she's on it. So just keep that in mind. Penicillin are beta-lactams. Amoxicillin is another name for a penicillin, Zosyn, Unison. These kill gram-positive, some gram-negative, high allergy rate, cross-sensitivity with cephalosporins. So you can take a look at some of these. Again, these are very good drugs. Matter of whether or not a patient has allergy to penicillin or not. Macrolides, erythromycin, Z-Pax, zithromycin. These are great too. Bacteriostatic, and with high doses are bactericidal. They used for a variety of things: strep throat, flu, flu-causing bacteria, a bacterial type flu, gonorrhea, chlamydia, Lyme disease, syphilis, H. pylori. So a lot of people who get sick will do very well with a macrolide because but the only one side effect is some people can't take them because of GI upset. So some of them have like bend over pain when they take them for GI. So taking them with food often helps. And that's not exactly an allergy. If you have a GI upset, it's a side effect. So patients can take them if they have that side effect. They just may need to suffer through it if there's nothing else that they can take. Here's some tetracyclines. And these also are useful for many bacterias. And you can see there's a list of things they're useful for. A lot of patients will take these for acne. But look at the variety of different other conditions they could be useful for. You can't use these in pregnancy or children under 8 because it can discolor the teeth and the tooth enamel, and it impairs fetal development. So, and then avoiding direct sunlight, more susceptible to burning. Here's your aminoglycosides. These do have a nephrotoxicity and an ototoxicity, so they can cause hearing or deafness, and they can also cause kidney damage. So these are some that we really are careful with and only use them if we absolutely need to. Gentamicin, tobramycin, and they also need to be monitored, their peak and trough. So we monitor levels because they can become toxic. So we'll look at their kidney functions, monitor the levels that they get, and make sure it's at a level that's going to work and that we don't do damage to the kidneys and the hearing. Quinolones, ciprofloxacin, levofloxacin, moxifloxacin, these are great drugs. However, they can cause a prolonged QT interval on the EKG. So if you use these with other drugs that do that, then you can certainly put the patient into VFib arrest or another, arrhythmia that can be dangerous. And they should avoid taking these within an hour of antacids, iron, or zinc. So again, you see there's quite a lot of considerations and side effects that we have to think about with any antibiotics and microbials. Vancomycin, this one is used for C. diff or MRSA. We try to save, this is one of the big gun ones, and we try to save this for patients who are resistant. So these would be patients who are not getting effect from the other antibiotics anymore. We give it slow IV infusion. We have to watch peak and trough levels. Nephrotoxicity and ototoxicity are other side effects, so we do have to monitor their kidney functions. And another side effect is red man syndrome. It's caused by a hypersensitivity reaction of the medication. So that's another thing we have to look for. So again, here are some goals. If we have a patient on antibiotic, we want to obviously have the infection go away. And these are some things to think about. Do they have decreased fever, pain, redness, drainage? Are their white blood cells going down? Have we followed up on blood cultures or urine cultures? Have we seen an increase in their appetite, activity, and sense of well-being? So those are goals for sure. So antivirals work a little different. There's 6 classes of DNA and 14 classes of RNA viruses. So there's a lot of different types of viruses. And then so we have many types of antivirals that kill the virus, usually by preventing it from replicating. So if once we stop it from reproducing itself in a host cell, viruses are interesting. Bacteria can just grow in and with our cells, and the antivirals have to have a host cell in order to replicate. So they take our cells and they infect them with the virus, with the DNA and the RNA, or the RNA, either one, and then they replicate that way. So you can see some of the sites of action here, how they actually, so they attach to the host cell, they uncoat the virus and enter into the nucleic acid of the host cell nucleus. They control either the DNA, the RNA, or both. And again, they assemble their little army of virions, they're called, and then they release them into another host cell. And it just keeps going and going like that until the body's taken over. There are some non-HIV viral infections that can be drugs that can be used. So acyclovir is commonly used for any of these things: herpes, shingles, varicella, cold sores of the mouth, and then there's another one that's similar to acyclovir, valacyclovir. Other infections that are not so HSVs can all be treated with this, but not HIVs. Then we have ribavirin that we've talked about with hepatitis. It's also used with the flu. Acelmavir or Tamiflu is used. So with hepatitis, we can also use interferons. HIV, we have a specific group of antivirals. So there are 3 different types, and that's why a patient usually has to take we call it a HIV cocktail to prevent the spread of the HIV virus. And then once those patient continues to take those, we can prevent them from getting full-blown AIDS. We'll talk more about HIV and AIDS in the PMP class, so I don't want you to worry too much about it in this grouping here, but just know I did post a really good HIV, there's 2 videos for HIV drugs, and I think it's worth watching those because it's basically it's a whole course in itself, but the videos kind of slim it down into just like some quick understanding of the drugs. I will talk about them a little bit in the other class too. So again, if the person doesn't get treated, they're going to have progression, which is going to affect the T cells, and then their T cells are going to diminish over time if the virus keeps replicating. That's what it really does. It attacks the T cells of the body. But the drugs that we use attack 3 different the virus in 3 different ways to eliminate it from replicating. So it does have unpleasant side effects, and that lots of nausea, vomiting, and some others, and that's why patients typically don't like to take them. Okay, the interferon. So these are just basically going to alert your immune system so it tells the immune system to kill these viruses and basically tells them to attack the viruses and cancer cells and stops them from growing and dividing. So they're usually given in these million of units and given IM subcure IV. And we rotate sites if they're given injections like they would insulin. If they have a severe liver disease, they probably won't be taking these, and the side effects are flu-like symptoms. And we usually give like a Tylenol with it to avoid the fever, headache. That can be part of the side effect because of the flu-like symptoms. Some of the things we treat with these are, chronic Hep C or Hep B, cancers like malignant melanoma, genital warts is another one. So, but anyway, that's what these are. And there's a lot of weird names to them, so I'm not going to try to say the names, but you can certainly look some of these up. And we can talk more about them. And I think I don't know if these are in your workbook this week. I tried to focus on everything that was in your workbook, but if you have any questions after watching this, you can certainly send me an email and I will try to answer your questions. All right, I'll see you in class.